Hello, welcome to this edition of Radnor Health Matters. My name is Linda Shaney, and I'm a member of the Radnor Township Board of Health. Today we're going to talk about women and heart disease. Most of these topics pertain to men as well as women, but today we'll have a special focus on women. Today we have two very special guests, Dr. Laura Immordino and Kim Mayhew, both of Bryn Mawr Hospital. Dr. Immordino received her Bachelor of Science degree from Ursinus College in Biological Sciences, and she received her medical degree from Jefferson Medical College. She completed her internal medicine residency at Thomas Jefferson University Hospital and her fellowship in cardiovascular disease at Lankenau Medical Center. Dr. Immordino is the recipient of multiple academic and Honor Society awards. She is currently a clinical cardiologist at Bryn Mawr Hospital. Kim is a graduate of the University of Delaware with a Bachelor of Science degree and from Hahnemann University's Physician Assistant Program. Kim has been a cardiovascular physician assistant and chest pain center coordinator for 23 years at Bryn Mawr Hospital. Welcome to today's Radnor Health Matters, and we'll be talking about women and cardiovascular disease. I would like to start by asking Dr. Immordino about the cardiovascular program at Bryn Mawr Hospital.
Well, first of all, thanks for having us. I've been happy to be a part of the cardiovascular program at Bryn Mawr Hospital for the past 16 months, and I'm very happy to be at an institution where we're able to provide a full range of cardiac services. We do everything from caths using the radial artery approach and peripheral interventions to ablation of complex arrhythmias, bypass and valve surgery. And as a cardiologist, it's great to be able to provide a full range of care from diagnosing and treating illnesses in the majority of our patients, both men and women. And we can do that all at our Bryn Mawr campus.
Yes, thank you for having me here today to join in this discussion on women and heart disease. In addition to the services that Dr. Immordino discussed, Bryn Mawr Hospital also offers its community an accredited chest pain center. Bryn Mawr Hospital, Lankenau, Paoli, and Riddle are all accredited chest pain centers with PCI capability. We received our accreditation through the Society of Cardiovascular Patient Care. Bryn Mawr Hospital received their initial accreditation in 2010 and was reaccredited in 2013. And what this means is that we've been able to show excellence in providing seamless cardiac care to our community in partnership with our EMS provider, on through our emergency department, our cardiac cath lab, our cardiac nursing units, the cardiac rehab department, and our community health department. In addition to this, we've been able to show that we've met all of our performance measures and have exceeded those year after year.
Would you discuss the magnitude of women and heart disease statistically, please?
Sure. Well, heart disease is the #1 killer of women. It causes 1 in 3 female deaths a year, so that's 33%. You can compare that to breast cancer, which causes 1 in 31 female deaths a year, about 3.2%. It's 90% of women have one or more risk factors for coronary artery disease, but really only 1 in 5 believe it to be their biggest threat. So it's important to draw attention to the matter because women tend to develop more atypical symptoms compared to men.
Thank you very much.
And when we talk about cardiovascular disease, it encompasses a lot of different problems. It encompasses arrhythmias, valve disease, heart failure, and heart attacks or coronary artery disease. So today we'll talk mostly about coronary artery disease, but it's also important to be aware of the whole variety of cardiovascular illness.
Thank you very much. Kim, can you elaborate on the number of cardiac patients seen at Bryn Mawr Hospital, as well as the number of cardiovascular procedures performed annually?
Sure. At Bryn Mawr Hospital, we see thousands and thousands of cardiac patients every year. Many of these patients get admitted with a diagnosis of congestive heart failure. Some have abnormal heart rhythms and heart attacks. And many patients present with just complaint of chest pain or shortness of breath, and they are observed for 12 to 24 hours to rule out other life-threatening illnesses. Many patients who are admitted will require some type of cardiac procedure, and we do almost 2,500 procedures in our cardiac cath and electrophysiology lab every year.
Wow, thank you. Kim, can you tell us what cardiac risk factors women should know about that contribute to cardiovascular disease?
Well, the cardiac risk factors are well delineated and are numerous. And I like to divide them between those that you can control or modify and those that you can't. The ones you can control are high blood pressure, high cholesterol, specifically high LDL cholesterol, tobacco cessation, physical inactivity, and being overweight, specifically if you carry that weight around your waist. We know that if your waist circumference is greater than 35 inches and you're a woman, that's a risk factor for heart disease. Diabetes is also another risk factor that you can control. Now there's a couple risk factors you can't control, and those are your age. So for a woman older than 65, she has an increased risk of heart disease. Obviously your family history or your genes are not something you can change, as much as some of us would like to. But anybody who has a first-degree relative, meaning a mother, father, or sibling who's had early onset heart disease is probably also at a risk for heart disease. And then race is another risk factor you can't control.
Good, thank you very much. Dr. Immordino, I've heard the saying, know your numbers. Can you tell us what this means, and especially for women?
Sure, it really means knowing where you stand in terms of your modifiable risk factors. So like Kim mentioned, there are some things you can't control, like your age or your family history, but other risk factors can be modified to improve your cardiovascular risk. So things like cholesterol. And with cholesterol, that's subdivided into a few different categories. Where we're concerned is really the LDL and the HDL. So your bad cholesterol is your LDL. And our goal is typically to keep that under 100, especially in patients who already have coronary artery disease. Sometimes we're even more aggressive and we want to get it closer to 70. It's considered high when it's above 160 and very high when it's over 190. And then your good cholesterol is your HDL, and with that, the higher the better. If we can get that over 60, that can actually be protective and can to some degree counteract some of your other risk factors. And then it's also important to know numbers like your blood pressure and your BMI. And what I think everybody should know is really their risk score. And there are ways that you can calculate it yourself on the internet. We can display some of the links to these websites at the end of this talk. But if you go to these websites, you can enter the information yourself. So you can put in your cholesterol, your BMI, your family history, whether or not you smoke, and in the end it will give you a score, and that's your percentage risk of having a cardiovascular event in the next 10 years. And you can see that if you change your cholesterol, if you improve your blood pressure, if you lose weight, you can see that you can significantly decrease your risk.
That's very interesting information. Thank you. Dr. Immordino, what are the signs and symptoms of a heart attack, and is there any specific or different signs of a heart attack women should pay attention to?
Well, everyone's different. Some people experience many symptoms of a heart attack and some experience none. In general, women tend to have more atypical symptoms compared to men. So it's not always the crushing elephant sitting on your chest type of pain that you learn about. Other things to be aware of would be more of a discomfort or a tightness, a squeezing, a pressure sensation in the center of your chest. And that can spread to your shoulder, to your upper back, to your arm, your neck, or your jaw. Some women experience a sense of sudden anxiety or weakness or fatigue with exertion. Some people will experience like cold, clammy sweats or heart palpitations or fluttering. It's not uncommon to feel abdominal pain or an indigestion type of pain, and that's can be seen in patients who have heart attacks on the bottom part of their heart, which lays right against the diaphragm on top of your stomach. Some women report feeling just sudden inability to catch their breath or shortness of breath. So there really are a lot of different symptoms to look out for, and again, some people experience a lot of those all together, and some might feel just one or none of those symptoms.
Thank you very much. So Kim, if someone thought they were having a heart attack, what should they do, and who should they call?
Well, if they're having any of the symptoms that Dr. Immordino just described, and you think you're having a heart attack, please call 911. Please do not call a family member or a friend to drive you to the hospital. We know that the safest thing to do is to dial 911. So that's the first thing you should do. And secondly, we recommend that you take an aspirin. If you have the chewable 81 milligram tablets around the house, please take 4 of those, chew them and swallow them. If you have the 325 milligram tablet, you can also chew that and swallow that as well. The only reason that we wouldn't suggest you do that would be if you have an absolute allergy to aspirin, or if that you have a known active bleed in your digestive tract.
Okay, excellent. Thank you for that
Okay,
clarification. So if a patient arrives to the emergency department having a heart attack, what would they expect to happen?
Well, the first thing is they would get an ECG and blood work. And those two tests in combination can look for a specific type of heart attack, which would be correlating with a sudden closed off artery. And if that's the case, then things will happen pretty quickly. They would go directly to the cardiac catheterization lab, where we would do a cardiac cath, and probably through the radial approach if possible. The way we do that is by inserting an IV in the radial artery in your wrist, threading a catheter up the arm to the top of the heart, and then injecting dye there. And that dye will fill the arteries that go around the heart. We take X-ray pictures as we're doing that, and that way we can quickly and easily see where the blockage is. If it's blocked, then we would do angioplasty to open it up, and that would encompass putting a deflated balloon through the catheter into that blocked artery and trying to open it and push the plaque to the edges of the artery. Sometimes it requires a little suction device or injection of medicines that can help break up that blockage. And then once it's open, we would keep it open with a stent, which is a little metal tube. So again, all of this happens very quickly. The longer that artery is blocked off, the more damage is done.
So that would lend itself to time is muscle, correct?
That's correct. That's one of our favorite sayings in cardiology is time is muscle. And what we mean by that is that the longer an artery is closed, the more muscle that dies. So it's so important for people to A, recognize their symptoms, B, dial 911, and then C, obviously allows us to get them the treatment that they need to get the blood restored to the heart muscle so that we can preserve more of that muscle.
Yeah, thank you for that clarification. So Dr. Imordino, if somebody comes to the emergency department with chest pain and they don't have a heart attack, what follow-up care would they expect to have happen?
Well, it can take a few hours for damage or distress to the heart to show up in the blood work. So typically those patients will be in the emergency room or in the hospital at least a few hours, if not overnight. And if that blood work remains normal, then they'll discuss with the doctor what tests would be best for them in order to look for more chronic stable blockages. And that will depend on their symptoms and their risk factors that we talked about. There's several different studies that we could do. There's a few different types of stress tests, and those are non-invasive tests or scans that look for blood flow to the heart muscle. We can now do high-resolution CAT scans of the heart arteries, and that allows us to directly visualize the arteries and look for the degree of blockages. And then we can always do the catheterization, which we spoke about, which allows us to directly visualize the arteries as well as treat if there's a blockage there. So there's really pros and cons to all of the tests, and it's an individualized decision, again, based on risk factors and the symptoms that brought the patient there.
Okay, excellent. Thank you. Dr. Imordino, I've heard news about the new cardiovascular guidelines for treatment and diagnosis of women for heart disease. Can you tell us a little bit about that, please?
Sure. Well, there's two recent updates that came out in the past 6 months or so. The first one's updating the cholesterol guidelines, and the newest updates, it really emphasizes the use of statin drugs to treat high cholesterol. And the big change is that they're no longer recommending any goal target levels of cholesterol or LDL, which we've been using for years. But studies have shown that by using those target numbers, it can often lead to underutilization of statins and overutilization of other cholesterol medicines that aren't in the statin category. And there really are so many other benefits to statins that's where these updates are really emphasizing. So if you have a patient that has a history of heart disease, who has diabetes, who has really high LDL levels or risk factors, high risk factors for heart disease, then there's not even a question based on their numbers. They really should be on a statin if there's no contraindication. It just gives us an idea of whether they should be on a moderate or a high level, high intensity of that drug.
Okay, so could you explain the new guidelines for blood pressure management as well?
Sure, so we have updated those as well. And the new updates really recommend less strict blood pressure control, especially in older patients. It's really a generalization, and there are still certain groups of patients, especially those with kidney disease or aneurysms, if they have other specific diseases where we would need to continue to be more strict in our blood pressure control.
Well, thank you.
Sure.
There's also been a lot in the literature regarding hormone replacement therapy. Should a woman take hormone replacement therapy, and is it indicated postmenopausal?
Well, in the past, it was thought that estrogen replacement would be beneficial for the heart, but the studies have really shown otherwise. The HERS trial, which is the heart and estrogen replacement therapy trial, has actually shown that there's an increased risk of heart disease, especially in women who start estrogen replacement therapy years after menopause. The Women's Heart Initiative has actually shown that there's an increased risk of breast cancer, increased risk of stroke and blood clots in people who are on long-term hormone replacement. So, in general, short-term hormone replacement therapy is probably safe in most women if they're taking it for perimenopausal symptoms. There are still categories where that's not the case. If you've had a previous heart attack or stroke, if you have a high risk of blood clots or blood clots in the past, then you really shouldn't be on it even in the short run.
Yeah, thank you very much for that clarification. And Kim, what are the things women can do to decrease their risk of developing cardiovascular disease?
Well, this is a topic that really gets me excited because, we recognize that people really, really do have the ability to impact their risk. And so there's a lot of areas that they could focus on. And there's a lot of literature out there for patients if they want to go and read, check out the internet, visit their local library, or even at the hospital in their libraries. There's a lot of information. But I'm going to focus on a couple areas. Number one, the AHA and the ACC recommend that we exercise for at least 40 minutes a day, 4 times a week. And that's with moderate intensity aerobic exercise. I encourage people to choose something that really makes them happy and that they like so that they'll continue to do it. Things such as, taking a brisk walk, walking your dog, swimming, playing tennis, golfing, gardening, even yard work and housework will meet that. And patients have to think about breaking it down even into small segments, so you don't have to do it for 40 minutes at one time. Dietary recommendations include eating a low saturated fat diet, a low cholesterol diet. We also recommend that you only consume 2,400 to 3,000 milligrams of sodium a day, and limit the amount of added sugar to your diet to 6 teaspoons. We like people to focus on eating, diets high in vegetables and fruits, as well as whole grains, poultry, fish, and nuts, and trying to avoid, foods high in saturated fat. Some of the foods that are really great for you are things like salmon, olive oil, avocados, nuts. In addition, we encourage all patients to please stop smoking. Mainline Health does provide free smoking cessation classes, and if you dial 484-227-FREE, you'll be connected with a smoking cessation counselor that can provide help for you. The other recommendations are that you see your primary care physician once a year. And in addition to that, try to reduce the stress in your life. And that can be done either with daily exercise or with meditation, yoga, and also with trying to just do one thing at a time, because we know in this society everybody's always trying to multitask, particularly women. And if you just try and do one thing at a time, that will really help reduce your stress.
Yeah, there's some great tips. Thank you, Kim.
Yes.
Really appreciate that. And Dr. Imordino, what is the importance of taking a daily low-dose aspirin?
So low-dose aspirin is really indicated in most patients that have a history of coronary artery disease. That would be secondary prevention in someone who's already been diagnosed with heart disease. It's been shown to decrease mortality, to decrease the chance of having another cardiovascular event, and unless there's a contraindication, they really should be on a low-dose aspirin a day. For patients who don't have a prior history for primary prevention, in most patients who have moderate to high risk factors for developing heart disease, that's also an indication. Again, I say most because there's risk in every medicine, so even a low-dose aspirin does increase your bleeding risk. So it's something that we're always weighing, which is more important, which is more riskier, being on a medicine or being off of it. So it's something that you should talk to your doctor about before starting. If you have certain bleeding risks, or if you've had ulcers or digestive tract bleeding before, it might not be good idea in that patient.
Yeah, thank you for that clarification. All right, Kim, what national resources are available for women for more information on the prevention and management of cardiovascular disease?
Right. Well, nationally we have the GoRedForWomen.org as well as heart.org. And locally, Mainline Health has a website that is mainlinehealth.org/heart. And I think we also are going to provide the phone number for smoking cessation class.
Correct. Well, thank you very much, Dr. Immordino and Kim, for taking your valuable time to come and talk to us today about women and heart disease. And I hope that the public has a greater knowledge of women and heart disease. And again, thank you so much for your time.
Thanks for having us.
Okay, thank you very much.